نبدأ إن شاء الله. أقول بسم الله الرحمن الرحيم ومرحب بالحضور.
أيوة.
مرحب بالحضور من السودان ومن خارج السودان، ونتشرف حقيقة بتقديم بروفيسور
أنا كنت تكون معي خلاص.
دكتور مغربي، دكتور صلاح مغربي، ابن he's a senior obstetrician، وعمل في بريطانيا وفي المملكة وفي السودان وفي دولة الإمارات، وهو الحقيقة غني عن التعريف للناس العجائز. قد يتذكروا العلامة دكتور عبد السلام مغربي رحمه الله، هذا هو والد بروفيسور صلاح مغربي، وكان أحد أعلام النساء والولادة في السودان لسنين طويلة، وما زال بروفيسور مغربي على خطى والده، ونتشرف حقيقة بمشاركته لنا في برنامج الطبابة في هذه الجائحة. ربنا يرفعها قريبا عن العالم كله إن شاء الله وعن السودان، ونتوكل على الله ونخلي بروفيسور صلاح مغربي يتحفنا بالعلم والمعرفة لمعالجة the complications of COVID-19 during pregnancy or the management of COVID-19 with pregnancy. فيتفضل بروفيسور مغربي. كلنا سماع.
Thank you very much. شكرا جدا يا بروفيسور عماد، يا بروفيسور معتصم، والدكتورة فاطمة وقت عليها. أولا أود أقول إن أعزائي جميع من وافقهم جميع زملائنا في المجال والعاملين في المجال الطبي أثناء تأدية عملهم في معالجة المرضى بمرضى الكورونا أو غيرها، وذلك في جميع البلدان في السودان، السعودية، الخليج، ايرلندا، بريطانيا، الولايات المتحدة، وإن شاء الله غيرها من.
دقيقة.
لا لسه. سريع.
أرجو من الجميع يعمل الميكروفون بتاعه ميوت عشان الأصوات من منطقتهم ما تشوش على المحاضرة. بس لو سمحت كل واحد يعمل المايك بتاعه ميوت.
اوكي، السلايد ظاهر عندكم؟
اي لا ظاهرة جدا يا بروفيسور، بس انت عاملها باور برزنتيشن.
اوكي كده ظاهرة؟
اي مظبوط تمام التمام.
اوكي. أول حاجة thank you very much Professor Imad for introducing me, and for Dr. Sisir for his diligent and very hard work during preparing this talk. I really am very happy to see Professor Mu'tasim around. Maybe he will learn something about obstetrics, inshallah. I would like to thank Al-Tababa Institution for inviting me to give this talk. I take this opportunity to express my admiration for Professor Imad for his perseverance and to establish Al-Tababa as a professional and educational institute. I just like to
اتفضل يا بروفيسور.
Okay. I would like to I followed my father, as Professor Ahmad has said before. I followed him in the specialty. I've never been as good as he was. He was the first holder of the diploma of obstetrics and gynecology in the 50s of the last century. It then became the master's degree, which I was very lucky and fortunate to have it. And now it's an MD, which, you know, the rest of young people who are or either have it or will have it soon enough. I'm very proud of it, and I'm very proud to be a member of the degree. Okay, now we move on to the lecture. The objectives of the talk are going to be, as you can see, are going to be mainly on obstetrics, on maternal complications in relation to COVID-19. And I would start talking about, I should give you a brief history on the corona and the facts about it, and who are at most risk, especially in the UK, where I see every the bulletins that come out. And then we're going to talk about the management of pregnancy and labor during COVID-19 pandemic. Oh, no. In the Wuhan sometime in
بروفيسور مغربي معلش في اصوات. الو.
ايوه.
لو في طريقه نقفل التليفون عندك.
ايوه.
يعني نبقي التليفون اوف، لانه في تشويش الحقيقه من عندك. في تشويش من عندك يا بروفيسور. الو. لو سمحت يا بروفيسور تطلع وتدخل ثاني، معلش. تطلع وتدخل ثاني لو سمحت. لا في الأحمر نقطع المكالمة يا بروفيسور وبعدين ندخل ثاني. يعني أيوة ندخل ثاني. أيوة مظبوط. ده كده أحسن يا دوب. أيوة.
اوكي. شير سكرين نشوف
أي شير سكرين. أيوة لو سمحت يا بروفيسور.
اوكي ظاهر عندكم؟
لا السكرين لسه ما طلعت. شير سكرين لو تعملها ثاني يا بروفيسور. شير سكرين.
start sharing.
ايوه بس افتح الباوربوينت لما اتفتحت.
اوكي ظاهر عندك ولا لا؟
لا لسه انا ما شايف الباوربوينت. انت شايفه قدامك ولا ما اتفتحت قدامك؟
يعني شايف قدامي ظاهر.
ايوه بس معناه ثاني نجرب ثاني شير سكرين.
start sharing ولا
ايوه لا هي بس نجرب شيرنج ثاني. سكرين شيرنج اوبشنز. ايوه
switch screen or window.
ايوه
that clear ولا لا؟
لسه ما طلعت. سكرين شيرنج ثاني.
screen sharing options.
كده ستوب شيرنج وبعدين جرب ثاني. يعني ستوب شيرنج وبعدين ثاني اعمل شير سكرين.
screen start sharing. no total slides يمكن I don't know.
ايوه الان طلعت.
اوكي
بس نعملها برزنتيشن ستايل. اي
ظاهر كده كويس؟
اي كده تمام. تفضل يا بروفيسور.
اوكي بسم الله الرحمن الرحيم. All right. We just to give you a very brief history about the COVID pandemic, which I'm sure you all know It started in Wuhan province sometime towards the end of December 2019, and was originally found in bats and pangolins. And pangolins are scaly creatures that eat ants and termites. And they may have been the intermediary host that then passed on to humans. It was declared, COVID-19 was declared as a public health emergency of international concern in January 2020, and then became declared as a pandemic on 11th of March 2020. It's also known as coronavirus, corona SARS virus 2, because of its genetic relationship with the SARS-2, with the SARS virus. Okay. Now, just a little bit about the COVID-19 virus. It's a novel virus. It's a new one, and we know very little about it. But we're gathering information every day, and every day there are new findings and so on. It's part of a large family of the SARS, of the coronaviruses, of the SARS and the MERS, and appears to be less severe than the SARS and the MERS, yet more contagious, because it sort of makes it easy for it to be transmitted because of our behavior, our human behavior, or its communication behavior. We tend to shake hands, we need to hug, and we need to talk in very close close encounters. It is transmitted by aerosol spread, by coughing or sneezing or even talking, provided the distance is less than 2 meters, and by via fomites, which are substances or objects, solid surfaces, woods, plastics, doorknobs, soil, clothing, and so on. It appears to be that we tend to touch our faces about 200 times a day. And through aerosol spread and through touching those fomites, we tend to spread the virus. The severity of the infection depends on the duration and degree of exposure, and that's very evident now in the fact that so many nurses, doctors, and people who work in close proximity to other people have a severe infection. It is not a very serious one as SARS and MERS yet. Patients can develop severe symptoms, and when they do, they will develop acute respiratory pneumonia, and which may progress to ARDS in critical cases. It's also responsible for enhanced clotting in severe and critical conditions. That's all very important for us when we talk about pregnancy. Now, who are at risk? Everybody knows the elderly, like me, are more at risk than anybody else, especially if there is a comorbidity of diabetes or hypertension or any other disease. But be very careful, because again, young people can be affected by the disease, and it can be severe illnesses, as demonstrated in some of the cases. But there will not be as many as the people who are at an older age, beyond 70, and especially if they have comorbidities. Obesity seems to be an important factor also in that sort of risk factor, or a risk factor. We'll talk about pregnancy independently afterwards, but I would like to emphasize that the close proximity and the duration of exposure to the virus is very serious. And that was demonstrated very clearly in the healthcare providers and care home staff and bus drivers and people who come in close contact with people who may be COVID-19 infected. Now, in UK, there is a real concern about the BAME, people who are for Black or from ethnic minorities. And it seems that there is a larger number of those people affected by the disease than the white population. and many people they're trying to explain. There's a lot of discussion on television and radio and so on about them. It seems to me, it seems to a lot of people, that those people are the ones who are nurses, the ones who drive buses, the ones who are in close contact with other people, and a lot of them work in ICUs and high dependency units. Of COVID-19. All being easygoing about children. We say children are practically go without even showing symptoms. And that's true to a great extent, except for the fact that there's a very small number in children who may have a serious illness called serious illness of infected vasculitis, which may lead to cardiac anomalies and cardiac aneurysms, very similar to Kawasaki disease in children. So beware, even in children, one has to be very careful in assessing them. Okay, we go to pregnancy. Now, why is pregnancy high risk? To start with, we know very well that pregnant ladies respond poorly to acute viral pneumonia. That's our experience in the past. When patients had flu or SARS or MERS, they behaved in a very serious way as compared to non-pregnant ladies. There are associated physical changes because of the growing uterus in the abdomen. It presses on the lung and displaces the lung a little bit, and the lung has to change its tidal volume to compensate for that change in anatomy. Pregnancy is known to be a hypercoagulable state, and we know with COVID-19 there is enhanced clotting. So the combination of two can make it very serious. And we know for pregnant lady to accommodate a fetus or pregnancy has to downgrade her immune system to some extent. So all these combinations put the impression that pregnant ladies may behave adversely to COVID-19. But here is a surprise, or here is the good news for the young ladies who probably are attending now, that females are more superior than males. I never thought I would say this, but it's true. There's a very nice book produced by geneticist. His name is Sharon Molim, in April 2020, in which he explains the genetic superiority of females have XX chromosomes, and each chromosome has 1,000 genes. That's the estrogen. It seems that those genes interact, cooperate to give women better survival throughout life, and especially in famines and pandemics, and also improve on their immune or make their immune system rather superior to men. That is also with estrogen. Estrogen is a very good hormone. We don't have it, unfortunately. The XY genes, as a male, we have a useful 1,000 genes from the X, but a useless 70 from the Y, plus the testosterone. The outcome of that is that it will be less survival, especially in famines, and our immune system is rather inferior to the female. And that has been demonstrated very clearly. A lot of patients in intensive care units and high dependency units, patients who developed severe illnesses, a lot of them were males as compared to females. Okay. Now, before I go on, we talked about the BME, the Black and ethnic minorities, and patients who are pregnant, and from those minorities, especially Bangladeshis and South Asians like Pakistan and India, may have worse outcome from COVID-19. Okay. Now, the clinical presentation. We have a problem with asymptomatic patients who are probably in incubation period or show extremely mild symptoms that they even don't feel that they are sick. And those can be extremely a very good vehicle of transmission of the disease. I don't have a number, but that seems to be one of the problems associated with COVID-19. A lot of them is a mild disease in many ways, because if you compare it to, if you look at the non-pregnant patients who develop COVID-19, a lot of them have very mild symptoms to moderate, about 81%. Some of them may develop severe disease, about 14%, and only 5% have critical, develop critical symptoms and signs and disease, with possibility of ARDS and enhanced clotting, and 50% of them pass away, unfortunately. Now, if you compare this to patients who develop COVID-19, that is acute viral pneumonia in pregnancy, when their age, usually the ones studied are between 18 and 30, we find that
can we have everybody please switch off their phone, their microphone, please?
Okay, I'll repeat the slide again. In acute viral pneumonia in pregnancy, which is part of it is COVID-19, as we compare it with SARS and MERS and the flu, it seems that pregnant and non-pregnant have equal opportunities. Develop mild to moderate are almost 86 to 81%. The ones who develop severe illness are 9.3, and the ones who go into critical conditions are 4.7. 50% of them will unfortunately pass away. That's very comparable to the non-pregnant pregnant patients. So whether a patient is pregnant or not pregnant, she seems to have an easier outcome or a better outcome than other coronal virus diseases or previous pandemics. Now, if you compare that, I'll come back again and try to show you the difference. Patients who develop acute viral pneumonia because of flu may have a fatality rate of 8 to 27%, as compared to the non-pregnant who not more than 1%. If the SARS, it will be 25% compared to 10% of non-pregnant, and in MERS is up to 27% as compared to 22%. So all in all, a lot of patients who develop or have COVID-19 disease seem to get away, most of them get away with a very mild to even not more than moderate disease. And that is comparable to the same in women. Pregnant or non-pregnant seem to be the same case, this outcome. Now, a very important point that I would like to make it here. This statement was made by Professor Asim Kojak. A lot of people know him. People from the field of statistics know him very well, because he's the one in charge of the Ian Donald School, and he's also a founder member of the World Association of Perinatal Medicine. And he tells us that the quality of data to this date are very poor. They're not good qualities. And they don't give us enough information to guide us on how to manage COVID-19 infection, and how bad the disease is, and how the extent of the disease, and how can it develop, and how can it be conquered. This information has been again related today in the Lancet. Some papers were rejected or redacted because the information was not as good as it should have been. So we hope in the future that we have good quality papers, good quality research, evidence-based and randomized controlled trials and so on and so forth, so that we can know the extent of the COVID-19. It's going to stay with us for a long time, so might as well try to know how bad the disease and how to conquer it. Having said that, now we go into maternal mortality. And it's a very important issue here, because I would, as an obstetrician, first thing I think of, if a patient develops COVID-19, would she die of it or not? And it seems that we are very lucky that the maternal mortality is practically very, very low. Okay, and it seems that we are very lucky in that way. Now, some papers came out of Iran and China, and but very small number of patients. Patients were very small, and especially in Iran, they studied 7 patients who I think 5 of them passed away. They had intrauterine fetal death and they had neonatal death, so it was a very, very serious problem. But it is a very small study, and we don't know the details of the patients, apart from the fact that they were older, at the age of 35 years or more. Now, the importance of the paper is not of the details of it, but to say maternal mortality is not absolute. It's not going to happen. It is going to happen, but in a very small number of people. So that has to be taken into consideration, that maternal mortality is very, very low, but not completely absent. What about maternal complications? We talk about miscarriages, preterm labor, maternal anxiety and depression, hypertension, preeclampsia, and placental changes. Now, just a minute, please. There's miscarriages. Now, apparently miscarriages are not as prevalent. We don't really know, to tell you the truth, because the COVID-19 pandemic has only been for 4 or 5 months, and it's not enough for us to study miscarriages. We know it may happen, but to this date, there's no evidence that miscarriages do occur. Maybe because we are dealing with 3rd trimester pregnancies rather than 1st and 2nd trimester. And maybe with time, as time goes on, then we'll have more patients to look into who may have miscarriages in the 1st and 2nd trimesters. But preterm labor is one that we need to discuss, and discuss very well indeed. Maternal anxiety and depression is definite. Hypertension and preeclampsia is presumed based on the fact that patients, am I okay? Hello?
Yeah, it is clear. We can see the slides and we can hear you very well.
Okay, good. We're talking about maternal complications, about miscarriages, preterm labor, premature rupture of membranes, maternal anxiety and depression, hypertension, preeclampsia, and placental changes. Now, I would concentrate a lot on preterm labor and maternal anxiety because they are factual. There is definite proof that they are occurring. Miscarriages, we don't really know, but we need time. As time goes on, we'll probably pick up more of miscarriages. At the present time, there's no evidence of miscarriages in the 1st and 2nd trimester. Hypertension and preeclampsia is a presumed outcome of COVID-19 based on the fact that pregnancy is hypercoagulable state and severe COVID-19 is associated with hypercoagulation. So it is logical to think, patients can develop hypertension, can develop preeclampsia and eclampsia, and can develop intravascular coagulopathy. But there's no proof, and there's definite intention to carry on with a lot of research to confirm or remove that possibility. Placental changes, we're going to talk about it. At the present time, there's no evidence that there are placental changes. An important statement here is, unlike past respiratory illnesses, acute virus pneumonia due to SARS and MERS and so on, pregnancy loss does not seem to put women at risk of worse outcomes from COVID-19, according to the first 6 weeks of birth to women in the UK during the COVID-19 era. Now, this is because of a very nice study performed by the United Kingdom Obstetric Surveillance System in association with Royal College of Obstetricians and Gynecologists. And that was done on the 11th of May, so quite recently. And they studied quite a number of patients. The majority of those patients were discharged home. They may have had mild, moderate disease. Maybe a small number of them had severe and got away with it and discharged home. Only 5 died, and the majority of those who had the disease were the 3rd trimester. And as the 3rd trimester progressed, they became more ill and probably more severely ill towards the end of the pregnancy. The risk increased if they were from the ethnic minorities of BMAE, if they were more than 35 years of age, and if they had existing pre-existing medical disease like hypertension and diabetes, or they are obese. So when we come back to miscarriages, we know that we think that patients with mild and moderate don't have any evidence of spontaneous miscarriage. There's no evidence. And there's a presumption that patients with severe COVID-19 may miscarriages up to 3%. But the studies are very small ones. We need evidence-based literature for us to study. What about preterm birth? I think preterm birth is a very important issue for quite a number of reasons. 13 final studies were included between December and March. 7 patients delivered between 30 and 33 weeks. And 30 patients delivered between 34 and 40 weeks. And I presume there's a number of them between 34 and 36 weeks. So anybody who delivered before 36 weeks is to be considered as preterm labor. Now, it is very important to look into preterm birth or preterm delivery. Why? Is it because of an obstetric event? Is the patient went into labor, had a premature rupture of membranes, and whether she had COVID or not, that was irrelevant? Or is it because she has COVID-19, and I, as a physician, got worried and saying to myself and to the patient that, if you are pregnant, then you may develop severe disease. So you might as well deliver you so that we decrease that possibility. That came out to be wrong assessment. So is it the obstetrician who drives the patient into delivering earlier than she should, on the presumption that the earlier patient delivered, the less energy? What brought that important discussion was the fact that 96% of patients had cesarean section. That's exceptionally high. With 59.9% of patients had confirmed COVID-19. It seems that we as obstetricians tend to intervene in goodwill and say, well, the patient will be much better if we deliver them. And the sooner we deliver them, the quicker we deliver them without subjecting them to, the intensity of labor by performing cesarean section, the better for I don't know the exact numbers, but it was, either elective or emergency. One patient was reported in UK, where a pregnant patient who was not for resuscitation, had a postmortem cesarean section of a live baby.
Yes.
Right.
Malone?
Yeah, okay. Am I doing okay? Yes. Now, the other serious complication. Hello? Other serious complication. Oh, hello? 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 Hello?
هبدأ بقطع.
Yes, doctor.
Hello?
سكر عيال مننا.
Hearing us, yes.
سامعين كويس؟
سامعين.
في أطفال ولا كده ممكن؟
سامعين كويس.
في أطفال في
المحاضر سامعينه كويس، لكن في ناس فاتحين المايكس بتاعتهم.
background.
الفاتحين المايكس بليز اقفلوها، اعملوها ميوت.
Okay, the second serious complication is anxiety, depression, and post-traumatic stress disorder. The studies were from China and a very good study from Italy. And it seems that the anxiety percentage is so high, from 70 to 77%. And we know that patients who are pregnant and post-pregnant and post-delivery may have 10 to 15% anxiety rate of anxiety, and 13 to 19.8% after birth, whether that is worldwide or in developing countries. So the amazing rise in anxiety and depression has to be noted and has to be looked into. The study from Italy was a very good one. It was through a questionnaire. It was done at the time of lockdown, where patients were told not to go out. People were not to leave home. They were Caucasian. They were married. A lot of them were nipplers. They had a spontaneous conception. A lot of them were educated with a good career. And some of them had pre-existing anxiety. But the point is, there was a very high level of anxiety. Now, if we look at the reasons why, most patients were at the age of 18 to 31, and it was the anxiety and depression was related to the severity of the infection. They were worried about antenatal care after lockdown, how they're going to be looked after. They were worried about delivery, where they're going to be delivered and how they're going to be delivered and who is going to deliver them. And will that be in a general hospital or in a maternity hospital? Will the delivery be a spontaneous vaginal delivery, or they will have to have cesarean section? What outcome? What outcome is expected, or what would they expect as an outcome? If it's very early pregnancy, is it going to be a miscarriage, or is she going to go into preterm labor, or is she going to have fetal anomalies and fetal intrauterine fetal death? And what about post-delivery? Would she be able to handle the baby and carry the baby herself, or will she be deprived of that and the baby to be taken to a neonatal unit? Will she be able to breastfeed? Will the baby develop infection? Unfortunately, until recently, most of the information comes about COVID-19 comes from or came from the media, whether lay media or medically simulated media, people who appear to know a little bit about medicine. They have their websites. 93%, while actual medical media were only doctors who reported, who engaged in explaining the outcomes of pregnancy, were only 7%. The next slide is practically the same, but this is very important to emphasize on that. Patients worried about, is it going to be like the Zika virus? Am I going to die if I get severe illness? Who's going to deliver me? Some patients or pregnant ladies have birth plans, and they would say to their midwife or doctor, how would they like to be delivered, whether that should be done at home or in hospital, especially in some countries. But will those birth plans be valid? Will they be adhered to? What about their babies? Are going to have intrauterine growth retardation or restricted fetal growth, intrauterine fetal death, or intrauterine fetal infection? And the postpartum, as explained earlier in the previous slide. Now, what about the possibility of hypertension, preeclampsia, disseminated intravascular coagulopathy? All these are presumed complications, but not proven. And we may need time and more intense research, evidence-based and randomized, to say that does occur. But we presume it's not clearly evident yet. Now, what about placental changes? In a nutshell, there are no placental changes. But in very small studies, one of them is one study, showed extensive fetal thrombotic vasculopathy. Others showed placental infarction, increased fibrin deposition. And because the studies were so small, and most of the other studies did not show any placental changes. So we accept the fact that there are no placental changes. But it's worth a study. It's worth, starting to look into it in a more extensive way to determine any thrombotic effect of COVID-19 on the fetal placenta in the first and second trimester. And that's one study that, clever people like you should start. What about perinatal studies? There were 51, and 49 of them were in the third trimester, none in the first trimester, and only 2 in the second trimester. So our perinatal studies were only concentrated in the third trimester. That's a very important issue now, the vertical transmission. Would the virus be transmitted from the mother through the placenta to the fetus or not? To this date, there's no evidence of vertical transmission. So we presume and we accept it is negative, even though there were 2 studies. One where 33 out of 33 newborn, 3 had positive IgM 2 days after delivery. So 2 days are not enough to be incubation period. So the presumption was it must have occurred in utero. And again, we go back to the study of Iran, where the patients had severe illness and passed away, and also had 3 intrauterine fetal deaths and 2 neonatal deaths. But on the whole, there is no evidence. And a lot of patients were studied, and there is no evidence of detectable viral DNA in amniotic fluid or serum placenta or breast milk or vaginal fluid. Which is very good news. So we accept and we say there is no vertical transmission until proven otherwise. There is no evidence of intrauterine fetal death, small for gestational age or neonatal death. in COVID-19 as compared to the flu, SARS, and MERS. So we conclude the following: that pregnant and non-pregnant women infected with COVID-19 have similar outcomes in terms of severity, admission to intensive care units, and morbidity. Preterm delivery and and mortality, have similar outcomes. Preterm delivery and high incidence of cesarean section needs further evaluation. And this is very important because we should not interfere and cause harm as obstetricians. More evidence-based studies are needed to resolve the issue of vertical transmission because, again, that's a very important issue in terms of outcomes. And the fact that a lot of people accept that COVID-19 is going to stay with us or live with us for quite some time. Again, what are the complications that are likely to happen in the first, second trimesters? And we have the time to study that. What are the psychological impact of COVID-19 on pregnant women must be addressed by professional bodies rather than media, because it is a very serious problem. Patients do have a lot of anxiety and PTSDs. And based on the current information, management of pregnancy should continue in the same way as if they did not, or in the pre-COVID-19, with some precautions, which we'll discuss later, shortly. What's happening now? My computer froze. Okay. Now, discussion was how should we manage professionally as obstetricians management of pregnancy in the COVID pandemic period or era. First of all, antenatal care. What should we do in antenatal care? We know that patients or pregnant ladies tend to visit their obstetrician or midwife at regular basis. Quite a number of them is because just they want to discuss a few issues here and there and make sure everything is fine. Other times, important is times when certain investigations have to be done or ultrasound has to be done. Now, if we look into all that, we should say there should be enough virtual clinics where the pregnant lady can discuss with her midwife or obstetrician any sort of worries or certain things that they want to ask about. So virtual clinics are here to stay, and they're a very good way of communication with the patient. But then there should be designated clinics for asymptomatic pregnant clients and symptomatic. There should be those designated clinics where patients can go and visit their clinician or a midwife. And there will be special designated clinics for those who are positive, mild COVID-19 infection. I presume patients with mild to moderate may be locked down at home or self-insulate at home, and the severe ladies would have to go to hospital. And the patient with severe illness have to go to hospital. So I presume that the patients can be seen in a designated clinics for those who is positive, and designated clinics for those who are not positive or negative, or in the same clinic itself that they can be segregated. Most important of all, that the clinician or the midwife should have personal protective equipment, because she will see patients from different backgrounds and different patients. So to prevent transmission, personal protective equipment are very important. Investigation will be done the same. And other obstetric clinical practice does not change, or should not change. Now, the very important thing that I could come about is lung scan. There was a webinar on the 9th of May by the World Association of Preventive Medicine. And a young Italian obstetrician explained the importance of lung scan as due to chest X-ray. And the nice thing about it is it's very it's not it's very safe. It can be done. The learning curve is very short, very small, and both obstetric technician, ultrasound technician, or the obstetrician can learn very quickly how to perform it. The good thing about it is it can be done whenever a patient comes to visit the clinic. So it's good of regular monitoring of what's happening to the lungs. Something is happening again. Okay, now what about patients who have to be admitted to hospital? Because they would be admitted for either of two reasons, either obstetric complications or they have COVID-19 related complications. They're very simple. Patients with severe illness that may develop into critical, they should be treated or looked after in the same way as they would look after other patients who are not pregnant, who have developed severe COVID complication. Those patients will be admitted to high dependency unit or intensive care unit because they will need intensive supportive treatment with oxygen therapy, CPAP, and ventilators. So there's nothing more to discuss, and the pregnancy becomes a second sort of, or comes second to management of the patient. Patient has to, the doctor will have to try and hopefully keep the patient alive. But what about those asymptomatic but positive or mild or moderate? Then, or they don't have any. They just such a complication, but they are negative for COVID-19. There are two ways of doing it. Either you shift the whole maternity unit to another hospital where there's no evidence of, or where COVID-19 patients are not treated or even allowed to come close to that. And they call that frame shifting. They're reassigning the hospitals. That a hospital will be designated for maternity. And in that maternity hospital, then patients can be segregated into a patient who is positive COVID or no positive COVID. And labor and delivery can be arranged accordingly. Okay? Or ring fencing. If there's no possibility of transferring patients to another hospital, another institution, then they do the ring fencing, which isolating designated wards for maternity and labor ward and OR and so on and so forth. And it's very successful and it's very good. It gives peace of mind to the patient and it avoids transmission of disease from other patients who are not pregnant or, and so on. So same applies to labor and delivery areas where it can be shifted. It can be rearranged. Now, if a patient has mild to moderate disease, what should we do? And she's pregnant. We know there's no serious illness, there's no serious problem related to that affecting her or the fetus, or the fetus, or the mode of delivery. So we should avoid planned preterm delivery. We should not be frightened. We should allow them to carry on with the pregnancy until we know that the fetus in utero is safe to be delivered without any postnatal complications, or as little as possible. Mode of delivery should be according to the obstetric, or should be obstetrically indicated. Spontaneous vaginal delivery if it's possible, assisted vaginal delivery if it has to be done, or lower segment cesarean section if if there's need for it. Should we look at birth plans? Maybe we can do that, but we have to warn the patient. There's no pain relief with epidural, simply because anesthetists are not going to be around to provide that. Where can the patient be delivered? It would be in designated labor and delivery areas with segregation of patients with no symptoms and no evidence of COVID versus those with COVID, and maybe rooms rather than wards. Now, just bring this issue here of something I thought about, that in Sudan we have the very vast experience of a diet, and that midwives have a big role to play in our community, whether that community is in Khartoum or in small towns or in villages. So we can accept the concept of birthing places or birthing homes. I mean, patients who may be delivered in specially designed birthing places, where in close proximity to a hospital. And those birthing places will be very well designed and completely managed by midwives, with the presence of a doctor if they need to. Something to think about, and maybe it would be a good thing. I mean, would be a good sort of in lieu of fencing and developing the concept of shifting patients. Severe and critical patients are treated as non-pregnant patients, because it's now treating the disease rather than the obstetric event. Now, there are a lot of talk about drugs that have been used in COVID-19, and we know about the story of hydroxychloroquine, and that now is definitely not going to be used. And WHO, I think, CDC and FDA recommended that it should be stopped. And we know who has recommended it, and it's a long story, and everybody laughed at it and so on. There's remdesivir, which is a viral treatment, and that was used for management of patients with Ebola. And ongoing studies are on, and patients are big trials are being performed. Another important one is the convalescent plasma therapy, which is very, very good. I think it's ongoing here in UK. And today, the Minister of Health told us that he gave his blood because he was positive, but he had mild disease, and he gave his blood to develop for plasma therapy, which is very good. Something to think about it, and is available. Now, a couple of days ago, they start talking about ibuprofen, which is in a special formula containing, I think, lipid, and it seems that it is quite effective. And of course, vaccines are ongoing. And today there was an interview of AstraZeneca, and they're going to produce about 2 billion vaccines by September. These are the references. And you look it up and you find a lot of good information. Thank you. And I'm sorry. Okay.
Barakallah Fik, Professor Moghraby. Well, thank you very much really for an excellent update on pregnancy and COVID-19. A very timely update, very comprehensive, many interesting information, lots of questions. If I might start, I was actually a small comment. I'm actually interested to hear about the better biology and immunology in women. This is a very interesting statement. I think immunologically, yes, we know women are better immunologically because they get lots of autoimmune diseases. So that's not surprising. But the biological part, this is a bit debatable, I think. If I may be allowed to ask a question, if a pregnant lady has a severe disease and she is actually in ICU, would you actually advocate terminating pregnancy?
Very good question. There's not much information apart from that lady who had to have postpartum cesarean section. I think I would terminate a pregnancy if there is evidence that this fetus can survive after delivery. Because I think it's a matter of, I don't think the pregnancy itself is going to make any difference in survival when this patient is in severe or critical state. So if it is for the sake of the fetus, I would deliver them. But if she was in 15 weeks or 14 weeks or 12 weeks, it would be much more dangerous, I think, to try and terminate a pregnancy for both the one who's taking care of the patient and for the patient itself. She may bleed, things are not going to be in the correct way. So I think if there is a possibility that the fetus may survive if delivered, then I would go and perform cesarean section. That would be my decision. But earlier pregnancies, I will not terminate because I don't think it will make too much difference.
Right. Okay. That's great. Thank you very much. May I ask the audience if anybody has any questions? They are all welcome to ask. This is their chance now.
السلام عليكم.
عليكم السلام.
Prof. Moghraby. Thank you for the nice comprehensive presentation. أنا دكتور محمد الفاتح أخصائي باطنية وطبابة منبر.
أهلا وسهلا.
I would like to ask two questions. The
Yes.
first one, the patient with pregnant lady with severe pneumonia, when to decide to starting therapeutic heparin? The first question. The second question was about the escalation or de-escalation, to intubate, not to intubate. When to decide this very critical decision in these days. Thank you. Thank you so much.
Thank you. Thank you for the question. Very nice question. My answer would be straightforward. If a patient has severe COVID-19 infection, then that takes priority. And the patient will be treated just as you would treat a non-pregnant lady or any other patient with severe illness. In other words, they have to be admitted to a high dependency unit or intensive care unit. And I think there is a possibility of CPAP to start with because patients with who need ventilation will have to be anesthetized, and the outcome is very poor anyway. So people are taking this intermediate thing about CPAP, hoping that patient will recover better. But there's no way of deciding how bad that disease will progress. So I would ignore the pregnancy in that respect and treat the patient and try to achieve survival. So I would treat her as intensively as I would treat a patient who's not pregnant or a male. Sorry about the second question.
The second question is about starting therapeutic heparin in the case of pregnant lady with severe pneumonia. Any role for heparin, therapeutic heparin? Because we know that's one of the causes of mortality is pulmonary embolism.
Exactly. I think that question came about, but it didn't talk about pregnancy, but they talked about, they sort of recently the coagulation problem became very evident, and that they should be treated. Patients should have anticoagulants. And I think in a pregnant patient who is severely ill, you can start heparin much earlier, as soon as possible. Now, the question is, if she has intermediate disease or mild disease, should she start heparin? That's a very difficult question, because I think most of those patients will be most of those patients will be segregated or made to stay at home. Now, we give patients heparin to take home.
Is that your phone, doctor?
Yeah. Right, Taysir. Hello? Hello. Right, Taysir. الله يبارك فيك. الله يبارك فيك. لا عارف، ما في مشكلة. ما في مشكلة. لا أنا enjoying it. يعني الشباب قاعدين قدام حتى يعني I'm answering questions, so it's very good. أتكلم معك بعدين إن شاء الله وبكرة ها. Okay. Bye. So it's a good idea, and I think if a patient has, you may think about it, but most patients get away with having a very mild disease or even moderate, and they don't have to be admitted to hospital. So I think in this situation, I would go for giving anticoagulants when the patients are admitted to hospital. But just an assumption. I have no experience with that.
Dr. Mohammed Al-Fatih, would the D-dimer help you decide whether to anticoagulate or not, or would you still have to do a Doppler of the legs or a spiral CT before you start full anticoagulation? Because a pregnant lady, especially third trimester, severe disease, hypercoagulable state, we know that DVT in COVID-19 is mostly, or at least in 10 to 20% is asymptomatic. Would the D-dimer help you decide on anticoagulation even without doing Doppler of the legs or a spiral CT? Hello? Can't hear you, Dr. Professor Salah. Hello?
Maybe a good idea, I think.
Okay, so you would recommend doing a D-dimer as a screening test because it will be up in pregnancy anyway, isn't it?
Okay. Good idea. Yes.
Can I ask a question?
تفضل يا بروفيسور تفضل.
Thank you for taking us through this portion of the community. It was actually neglected in the recent literature, the Chinese literature and the radiologic literature, long time. But I want to raise one point. We are all experiencing an exponential learning curve. Actually, when at these cases, people tell you that it does not affect children, it does not affect the GIT tract, then we started learning the hard way that does all what was not supposed. So perhaps one may be keen to look at, on your side, to look at the question of placental changes and what you, because there is a lot of saying about the virus going through the CEM infected.
If you can come closer to the mic يا بروفيسور بس الصوت بيروح شوية.
Yes. What I was saying is that our learning curve has proved that what we thought not exist in COVID-19 has happened. Yeah. Initially, people said it does not affect children, then it proved to affect children in a severe way. Then it was not affecting the brain, it affected the brain. It was not going to affect the GIT, it's affecting the GIT. So maybe the exclusions that the obstetricians believe are, maybe by time, they should make sure that it does not prove to be true, as happened with other body systems. Now, this is just one caution, The other thing is the use of the ultrasound scan. Yes, ultrasound is handy. All obstetricians now have got very skilled fingers with ultrasound. came back to them because when Ian Donald discovered this, he snatched it away from their hands for quite a time. Then after, decades, found that we've got other things to enjoy. So we gave the toy back to the obstetricians. So they're all very good at it, and they can look at the lungs. They even look at the babies in utero lungs, because that's easier because it's all full of fluid. But my precaution is that if the patient is suspicious of COVID, or the community told has got some incidents, yourself and your patient have to be careful, have to apply all precautions. The problem with ultrasound, it involves long time, very close contact between the operator and the patient. And during this period, if any of them is carrying the virus, at least over 15, 20 minutes, or half an hour in that case, because you do the obstetric scan and then add the lung scan, one of the two might cough or sneeze, right? Because half an hour plus half an hour, 1 hour. So if he is a carrier, then there is a risk. So people have to be very careful selecting which patient to screen with ultrasound. And I think, that it still remains real-time PCR, remains the screening way for this very strange patent virus.
Thank you very much, Professor, for this point, because I think I didn't think about it that way, but it is true that the physician, or the clinician, or the patient may be exposed more than they should be. So that point is taken. As far as what we know very little about COVID-19, and I think we're developing knowledge as we go along. And it's amazing. I sit down, listen to the briefing of the National Health every day. Every day there are different findings and different recommendations. For example, today they're making it an order and for people to wear masks, when 3 days ago they said, well, masks are not really protective. Now, if you don't wear a mask in the train or the tube, then you can be fined up to £1,000. So things are changing. It's a very fluid thing that's happening. It's a very, very clever virus. It's causing a lot of disruption in people's lives. Hello?
Yes, thank you.
Question from Dr. Fatma, if we can hear the question, please.
Yeah.
دكتورة فاطمة.
Hello.
تفضل يا دكتورة، سامعينك. تفضل يا دكتورة.
Thank you for the very informative session. My question is that if the preterm labor is inevitable and I need to give a corticosteroid for COVID-19 pregnant lady to enhance the fetal maturity lung, what are the considerations and the precautions for use of corticosteroids in COVID-19 patient?
Okay. If the patient has, if the patient is in preterm labor, but there's no evidence of the COVID-19 being more than a mild disease, I'll probably do that. Most of us will deliver that patient this particular time, because we don't have experience enough, and we'd be too frightened to give corticosteroid. But it is one of the options. I think if I were to deal with a lady who was at 30 weeks or 32 weeks in early labor, I would do that. But if she comes to 34 weeks, I would refrain from giving steroids. But there's no evidence, there's no trials. Nobody spoke about giving steroids. If you notice the slide, 96% were delivered by cesarean section. And that's because physicians were so frightened of the patient developing severe illness because of the pregnancy and because of the preterm labor. So I'm sorry I can't answer you in a very clear way. But if I were in charge of a patient, and if she has 30 weeks, I probably would give steroids and then deliver her. But if she's 34 weeks or more, I will not. But that's just a presumption. There's no evidence that people have done this or done that.
Okay, thank you so much.
مشكور يا دكتور. We have دكتورة سناء. دكتورة الأقرع لو سمحت يا دكتورة سناء for your question.
السلام عليكم.
عليكم السلام
How are
ورحمة
you,
الله.
Prof? السلام عليكم. Thank you, Prof. Moghraby. Very nice lecture. I want to ask one question. We know that the healthcare workers are at a higher risk and the pregnant ladies are at a higher risk. So how we can give the best advice to our younger pregnant doctors? Do we advise them to continue their work with precautions, or we advise them to stop working during this difficult time? I want to hear your opinion. Thank you very much.
Okay, thank you very much. And if I were pregnant, I would run away from COVID-19. But since I'm not, I can give you this advice. The basic way of fighting COVID-19 to date is safe distancing, okay, washing your hands frequently, and having personal protective equipment. If all these are available, then there's no need for you to leave work, sort of contain yourself at home. I think if you observe this safe distancing, washing your hands, and wearing proper protective personal equipment, I think you should function adequately as in a non-COVID-19 situation.
If I may ask, Malaysia, because this is a very important issue, Professor, because we know of the lady from Algeria who died because of COVID-19. She was actually in her maybe third trimester, but she died, and at the end of the day, because she was not allowed to go off, and she died, and the responsible person who didn't allow her to go off actually was fired. So would you recommend that early pregnancy to continue, late pregnancy, second or third trimester to go home, not to continue to work?
Okay. If we apply the rules in non-COVID situation, patients who are pregnant in the third trimester can have a maternity leave.
No, I mean there's no maternity leave.
In the normal situation.
No, there is no maternity leave, but she is in the third trimester or second trimester. Would you advocate that she goes home or continue to work?
Second trimester, I wouldn't advocate. Even in early third trimester, up to 28, 30 weeks, it's not. I don't think it would be a big problem. I think from what I read about and noticed from briefings that the disease can be more severe when the patient goes into late third trimester, so maybe 36 weeks or even more than that. So it may be a good advice to say, well, you take your leave after 36 weeks, or you stop working. I said, depends on the country. And I think that would be adequate. But it's early third trimester and second trimester, if she or he are healthy and observe those precautions, then they should be okay. And maybe they can moderate the work. I mean, instead of going into delivering patient by cesarean section, they can do clinic. They can do virtual clinics. They can do a lot of other functions that will not endanger their lives.
Any more question, or because we are running out of time, actually. We are gone more than an hour and 20 minutes. Any more questions? Right. If no more questions, we thank Professor Moghraby once more for his great talk, very comprehensive, very enlightening. And I am sure lots of people will actually benefit from your advice. We're going to post it on our YouTube channel for more people to make use of this excellent information at this difficult time. Thank you very much once more, Professor Moghraby, Professor Al-Mu'tasim, and all the people who actually shared with us and attended this important session. Thank you very much.
Thank you very much. I'm very happy that I, see you straight, in the session. I'm very, very, very happy about it, and I'm very happy about Professor Mu'tasim and the young doctors who attended this talk. And I hope I'll be useful to you at any time. And I'm really going to speak to Taysir to arrange for more talks.
Right. Right. مشكورة دكتورة الأخت أميرة. She's an obstetric nurse معنا في الطبابة, if I am correct. Thank you for your presence with us. I hope you enjoyed the session as we have. Right. Thank you very much, everyone, and goodbye. See you again.
Salam.
Thank you. Bye-bye.
Thank you very much.